Good morning, everybody. So, as previously mentioned, a lot of the topics which we are discussing, there is an overlap, but this time I'm going to be looking at it from the other angle, and we are not discussing pallor, but we are discussing the cupped pale disc. So, if every disc pallor looked like this, and if every glaucomatous disc looked like this, then we wouldn't be having this presentation at all. But the problem is we are frequently presented with cases like this, where you have a patient presenting 1 month after cataract surgery, complaining of poor recovery of vision in the right eye, where the pressures are within normal limits, with a history of poor vision in the right eye because of mature cataract for many years. So you have a disc which is pale, there is definitely a central deep excavation, pressures are normal, so where do you go from here? So let's try to answer some of these questions. First of all, why do we need to consider neuro-ophthalmological disease in patients with glaucoma? It's because the same factors which we use to diagnose glaucoma, which are visual field defects, cupping of the optic disc, and an elevation of IOP, which may be present coincidentally because of the sheer prevalence of glaucoma, are the same factors which we use to diagnose a neurologic visual loss as well. So this has been emphasized again and again. The most important takeaway from my talk is that cupping can occur in non-glaucomatous disorders as well. The most common of these being compressive lesions of the visual pathway, hereditary optic neuropathy and ischemic optic neuropathy. Coming to the pathogenesis of cupping in glaucoma and neuro-ophthalmology, the important thing to remember that in glaucoma it is an ascending optic nerve atrophy, whereas in non-glaucomatous optic disc cupping it's a retrograde or a descending optic atrophy. A word on normal tension glaucoma, because this is the most common form of glaucoma which gets confused with neurological cupping because the pressures are normal. So NTG is characterized by cupping of the optic nerve head, visual field loss, open filtration angles and a normal IOP. Coincidental neurologic disease and ocular hypertension can be present, and many patients who present with POAG initially present with pressures lesser than 21. So in which patient do we need to consider, so we are talking about glaucoma patients, so in which patient with glaucoma should you consider an alternative diagnosis? So let's look at the history, the visual exam, the optic disc evaluation, the visual fields, and see if we can decide. So coming to the history, age is an important factor, and it's really specific. Age at presentation less than 50 years is very indicative of a non-glaucomatous problem. Again, a family history of glaucoma is a very specific indication. So if you have a patient in whom you're suspecting NTG with a family history of glaucoma, that pretty much puts your mind at rest. You may not need any further evaluation. A history of abrupt visual loss, rapid progression of visual loss associated with other neurologic signs and symptoms are indicative that you may need to probe this patient further. Coming to the visual examination, the most important factor in this, other than the actual visual acuity, is the presentation, because in glaucoma you have loss along the arcuate fibers first with sparing of the papillomacular bundle and sparing of the central visual acuity. So glaucoma presents with good visual acuity compared to the degree of cupping, whereas in a patient with a neurological cause, you may have a visual acuity out of proportion to the cupping, and the patient presents with a loss of central acuity. Coming to color vision, in glaucoma, the color vision tends to parallel the visual acuity, with good color vision being maintained till late, whereas in a non-glaucomatous cause, you may have severe dyschromatopsia, which is out of proportion to the cupping. RAPD, now RAPD is not something which we check for routinely in glaucoma patients. RAPD can be present in a glaucoma patient with an inter-eye disc asymmetry of 0.3 to 0.4. But if you have RAPD in a patient with presumed glaucoma with asymmetric cupping of less than 0.3, then this should raise suspicion for an underlying non-glaucomatous optic atrophy. Coming to the disc evaluation, again, rather than, we cannot decide just on the basis of only a single disc evaluation. The entire history and the onset needs to be considered. The most important thing which we need to see in this is that the onset of cupping in glaucoma precedes the vision loss. So you have this cupping going on for a long time before central visual acuity is affected. Whereas in a non-glaucomatous cause, the cupping occurs coincidental to or long after the actual visual loss happens. Coming to the NRR, this is probably the most important slide in the presentation. Looking at the NRR, this has already been mentioned. We need to look at the size of the cup and we need to look at the pallor of the rim. So like in the second slide, focal obliteration of the neuroretinal rim, especially extending to the disc margin, almost never happens in a non-glaucomatous cause. If you look at a disc pallor in a neurological case, you'll notice that the pallor extends much beyond the cup. It is difficult to differentiate where the cup ends and where the rim begins. So if the rim is pale, then you need to be careful. These are some other factors already covered which may indicate that it's glaucoma. Of these, the most important is the disc hemorrhage, which is crossing the neuroretinal rim. So if you have a patient with an NTG and the patient has a disc hemorrhage, that is almost 100% specific that the patient has glaucoma and definitely doesn't need further investigations. Presence of peripapillary atrophy and nerve fiber layer defects are also further clues. The problem is, again, when we have a patient like this with a huge cup and almost near total optic atrophy where the rim is not really visible, whatever left of the rim is pale. So then where do you go from there? I mean, looking at this disc, you can't really, based on all the factors which we have discussed, you can't really decide whether this is neurological or glaucomatous optic disc cupping. So that is when we look at the visual fields. Now, visual fields similar to glaucoma, which are nerve fiber layer defects, can be present in many neurological cases as well. So the important thing is not the pattern of the visual field defect as such, but whether it corresponds to the disc. So looking at the first field, you can see that there is inferior rim loss. There's a large inferior notch corresponding to a dense superior arcuate defect. Whereas if you look at the other field, you have a patchy diffuse visual field loss with a generalized depression which in no way corresponds to the disc picture. So we need to remember that arcuate distribution of optic nerve fiber bundles remain intact till the anterior chiasm. So compression of the intracranial optic nerve or the anterior chiasm can produce arcuate visual field effects with sparing of central vision, which can simulate a glaucomatous picture almost exactly. However, if you do have some typical neurological fields, then this will help to give you a further clue, like an inferior altitudinal defect with a patient with a history suggestive of AION or a dense central scotoma, or if you have lesions which respect the vertical meridian, which never happens in glaucoma. OCT, as has been discussed previously, does have some applications, especially to monitor optic disc atrophy, but it's very hard to use an OCT to differentiate between a glaucomatous cupping and a neurological cupping, because mean RNFL loss occurs in optic nerve damage of any cause. So we'll discuss some of the common causes of optic disc cupping which can be confused when presenting at a later stage in a non-acute phase. So optic neuritis can, when seen after recovery with cupping of the disc and residual field effect, can be confused. Like if you see an acute phase in this patient, you have a diffuse loss of field. However, after recovery, if you just look at the total deviation, this can, the patchy visual field loss can be seen to resemble a biarcuate field defect. Again, the thing to do is to compare it to the disc and to see whether the visual field loss is corresponding to the disc, and also it can be differentiated by the residual disc pallor, residual loss in color vision and contrast, or the decreased central visual acuity. Ischemic optic neuropathy, arthritic AION is one of the most common causes of neurological disc cupping, where 92% patients may develop disc cupping. In NAION, this is relatively rare. The visual field defect is typically arcuate or altitudinal, although any type of nerve fiber bundle defect is possible. RAPD is the differentiating factor. Coming to compressive optic neuropathy, space occupying lesion in the paracellular and the supracellular region may be associated with optic disc cupping ophthalmoscopically, which may be indistinguishable from glaucomatous optic neuropathy. Chaudhary et al. Have reported 6 patients misdiagnosed as glaucoma, in whom bilateral optic disc cupping was due to compression of the anterior visual pathway, and they have stated that a low index of suspicion is the main reason, where all the factors which we have covered, which includes a visual field defect which respects the vertical meridian and a pallor more than cupping, which were missed, which are the main causes why these cases get misdiagnosed. Coming to a short case to illustrate the same, this is a 32-year-old lady presenting with gradual decrease of vision in the right eye since 1 year with complaints of headaches, where if we look at the discs, then the pallor is definitely more than the cupping, although the right disc is definitely cupped. But when you look at the visual fields, there is definitely hemifield loss sharply respecting the vertical meridian, and on imaging you see a large stellar mass. This has been extensively covered, so there are congenital entities which can mimic cupping. However, they can be differentiated based on the visual acuity and the stability of the visual field, visual acuity and the visual field loss. So in summary, the features suggesting a non-glaucomatous diagnosis are a young age, rapid onset, rapid progression, headaches, neurological signs and symptoms, loss of visual acuity of field which are out of proportion to the cupping, severe dyschromatopsia, afferent pupillary defect without significant asymmetry of cupping, ocular motility or other neurological defects, atypical visual field where the temporal field is affected more than the nasal, respect of the vertical meridian, and typical neurological fields like an inferior altitudinal defect or a central scotoma, and most importantly pallor of the preserved rim. So finally, we'll take a look at a case and see whether we can apply all the points which we have learned and whether we can differentiate a glaucomatous cupping from a neurological cupping. So this is a 65-year-old male with complaints of gradual blurred vision in both eyes with history of hypertension and diabetes, presenting with a visual acuity of 612 in the right eye and 66 in the left eye with an applanation tonometry of 18 millimeters of mercury. So if we look at the disc, there's nothing significant which you can go on. It's a large disc. There's almost a near total cupping. There is no rim to speak of particularly. Whatever rim is left looks really pale, and there is a deep excavation. The other discs has a 0.3 cupping. The NRR looks healthy and pink. So if we look at all the factors which we covered, the age, he's 65 years old, that's definitely in favor of glaucoma. The history, there's a gradual loss of vision which is again in favor of glaucoma. The intraocular pressure is 18 millimeters of mercury, so can go either way. The visual acuity is 612, so central visual acuity is largely preserved. Color vision was normal. The disc cupping and pallor definitely looks neurological. Laterality is important because it's pretty much unilateral, which is again more in favor of a neurological cause, because glaucoma largely tends to be bilateral. But looking at all these factors, the overall picture, if it favors glaucoma, then you need to re-look at certain factors. So in this case, we just repeated the IOP again, and then we found that the IOP in the right eye was actually 26-28, and the field defect shows a dense biarcuate defect, which is definitely typical of glaucoma. So in conclusion, non-glaucomatous optic disc cupping and glaucomatous optic disc cupping can be differentiated by patient history, visual field assessment and clinical evaluation. Rapid progression and atypical visual field defects must lead us to consider an alternative etiology, especially a compressive lesion of the visual pathway. Thank you.